At a time when change is constant and we are pulled in far too many directions, we need a way to stay present to life and to increase our ability to remain calm, think clearly, and maintain our well-being. Many studies indicate mindfulness improves our mental, emotional, and physical health. On A Mindful Moment with Teresa McKee, you can learn how to practice mindfulness and enjoy its many benefits. Tune in for guided meditations and to hear tips and advice from some of the most respected experts in the fields of mental health and mindfulness. The world truly can be a better place. It all starts with a mindful moment.
Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips on how to thrive in nursing school and at the bedside. In this episode, we're going to be talking about a very common condition that I've seen many, many times in my patients with advanced liver disease, and that is ascites. Now, before we hop into that, let's take a quick minute for a listener shout out, and this shout out goes out to Tasha, who says this: I bought fast pharmacology to study for the NCLEX, and I am so glad that I did. I felt confident on the meds. Aside from the improved confidence for the NCLEX, I generally have a better understanding of the medications covered from fast pharmacology. Thank you so very much for creating this course. It is completely incredible. Tasha, first off, congratulations on passing your NCLEX. That's fabulous. I'm so happy for you. I remember that feeling well, and it really is a good one. And I'm so glad that fast pharmacology helped you feel confident understanding medications as you were going into that crucial exam. So if you're wondering what Tasha is talking about, she's talking about another audio-based program that I have called Fast Pharmacology, where I teach you pharm concepts and about 80 drug classes in 5 minutes or less. So if you want to check that out, go to straightanursingstudent.com/fast. That's straightanursingstudent.com/fast. All right, are you ready to dive into this week's episode? So again, ascites is something I've seen many, many times. And what ascites is it is the accumulation of fluid in the peritoneal cavity. And this accumulation of fluid causes abdominal distension, and in some cases, severe abdominal distension. Now, it's most likely and most commonly associated with cirrhosis, but it can also occur in other conditions such as cancer, heart failure, tuberculosis, and in patients undergoing dialysis. For the most part, though, when you see ascites, it's mostly going to be in a patient with cirrhosis. Now, ascites can really lead to some significant problems for your patient, including respiratory compromise, hypotension, and even peritonitis. Of course, there's a few others. We'll talk about those in just a moment. But first, let's go back and rewind ourselves back to our anatomy and physiology class and do a little bit of a quick anatomy review, which I realize is hard to do without visuals, but the key anatomical structures associated with this condition are going to be the liver. Okay, so the liver is a very key component when we're looking at ascites associated with cirrhosis. The hepatic veins. Now, the hepatic veins are going to be 3 sets of veins that drain blood from the liver, moving it into the inferior vena cava. And then when it goes from the inferior vena cava, it goes into the right side of the heart, then to the lungs, then to the left side of the heart, then out to the body. So that's the hepatic veins. They drain blood from the liver. The portal vein is the main vein leading into the liver, which I realize can be confusing. When we think of something going in somewhere, we tend to think of that as an artery, but in this case, it is a vein. And the portal vein provides about 2/3 of the liver's blood supply. And this blood coming through the portal vein is coming from basically the GI tract, and it's bringing nutrients from the intestines, and it's bringing some oxygen with it as well. And then that final component is the hepatic artery. And the hepatic artery provides about 1/3 of the liver's blood supply. And blood from the hepatic artery is full of oxygen-rich blood because the blood in the hepatic artery just came from the left side of the heart. So let's recap that really quickly. We have the liver, we have the hepatic veins, which are 3 sets of veins that drain blood from the liver, taking it into the inferior vena cava. Then we have the portal vein, which basically goes from the GI tract, the spleen, the gallbladder, into the liver, bringing a lot of blood supply, some nutrients, and some oxygen. And then the hepatic artery, providing about 1/3 of the liver's blood supply coming from the left side of the heart. It's got lots of oxygen in that blood. All right, so now that we've reviewed our anatomy, let's dive into the pathophysiology of ascites. So in patients with cirrhosis, and again, we're talking about ascites related to cirrhosis, the liver becomes scarred. And over time, this leads to hypertension in that portal vein. And this is a condition called portal hypertension. Portal hypertension is present when there is a difference in pressures between the portal vein and the inferior vena cava and or the hepatic vein. So we call this a pressure gradient. Usually this difference or this pressure gradient is less than or equal to about 5 millimeters of mercury. But when it gets up to 6 and higher, then we have portal hypertension. So we have higher pressures in that portal vein when comparing that level of pressure to the inferior vena cava or the hepatic vein. Now, when that gradient passes like 10 or 12 millimeters of mercury, this is considered clinically significant, and the patient will start showing signs and symptoms related to that portal hypertension. Namely, they'll be having ascites. Now, why this all occurs is it's one of those things in pathophysiology where there's a leading theory right now, and there's some old theories that we've kind of set aside, and maybe there'll be another theory in a few years. But the most recent and relevant theory for how ascites forms is the arterial vasodilation hypothesis. So this theory suggests that portal hypertension leads to arterial vasodilation due to increased nitric oxide synthesis. And we're not going to go into how that all happens. Just know that it has something to do with nitric oxide, which is a vasodilator. So vasodilation causes a relative hypovolemia. So what do I mean when I say relative hypovolemia? What we mean is that the volume of blood in the vasculature is deficient relative to the size of the vascular bed. Think of the vascular bed or the vasculature as a bucket. And when we have vasodilation, our bucket gets bigger. So now there's not much fluid in the bucket relative to its size. That's what we mean by relative hypovolemia. Now, over time, this leads to activation of the RAS pathway, the renin, angiotensin, aldosterone pathway, which ultimately gets us to sodium retention and increase in intravascular volume. So sodium and water retention. This increased volume essentially spills over into the peritoneal cavity, causing ascites. Now, another factor that can contribute to the development of ascites in patients with advanced liver disease is hypoalbuminemia, or a low albumin level. Recall that albumin is a protein that is made in the liver. So patients with liver disease tend to have low albumin levels. So this leads to reduced oncotic pressure in the vessels, which, when combined with that higher pressure, with that portal hypertension, causes fluid to leak out really easily into the abdominal cavity. So just a quick recap of that. We have portal hypertension leading to arterial vasodilation, and we've got nitric oxide involved in all this. That vasodilation causes the bucket to be too big. The bucket is the vasculature. So we have relative hypovolemia. And over time, the body thinks, oh no, we don't have enough volume. I need to do something about it. So I'm going to activate my RAS pathway. And this ultimately leads to sodium retention, water retention, and more volume. And this increased volume can spill over into the peritoneal cavity, causing ascites. Now, this can be compounded if the patient has low albumin levels, and that's because albumin is a great big protein, and it contributes a lot to oncotic pressure in the vessels. So if the patient doesn't have enough albumin, their oncotic pressure is going to be lower. That helps fluid leak out. We also have increased pressures in that vasculature, kind of pushing the fluid out, and this just really sets the patient up for ascites. Now, before we dive into the signs and symptoms of ascites, the tests for ascites, complications, treatments, and a case study, let's take a quick minute for a little bit of a break. I love hosting parties. In fact, my friends have called me the hostess with the mostest on more than one occasion. And a key ingredient to hosting a great party is having great wine to share. And with First Leaf, I always have fabulous options to choose from. And that's because First Leaf isn't your standard wine club. It's so much better. Instead of getting selections from just one winery, each shipment is a personalized selection of wines from around the world. And because of First Leaf, I've discovered that I love the white wines from South Africa, Washington, and Australia. Wines I probably wouldn't have discovered on my own. Not only have the prices been amazing, but the wines have been so good. I love a crisp, refreshing white wine, and First Leaf knows that. So that's what they select for me, and every bottle has been a winner. I can also tailor my membership. Choose 6 or 12 bottles, determine how many reds or whites I want, and even select a shipping window that works for me. So get wines to sip and share at your next summer party with First Leaf. Go to tryfirstleaf.com/nursemo to sign up, and you'll get your first 6 hand-picked bottles for just $44.95. That's tryfirstleaf.com/nursemo. Try firstleaf.com/nursemo. Now let's move on to talking about signs and symptoms of ascites. And the key thing that you'll notice about your patient with ascites is abdominal distension. And this can be mild to moderate to severe. And if it's severe, we call that tense ascites. Now, this abdominal distension could be associated with some abdominal discomfort or even pain. Generally, the greater the volume, the more discomfort the patient has. So that's one, abdominal distension with or without abdominal discomfort or pain. The patient will also have weight gain due to hypervolemia. They probably will tell you they have early satiety due to that increased pressure in the abdomen. So they feel full. They eat a little bit, they feel full. That's because there's already pressure in the abdomen. You add a little bit of food to that, they're going to feel that early satiety, like they can't really eat a lot at one sitting. Shortness of breath is a very common symptom of ascites, and this is, again, it's due to increased pressure in the abdomen, making it difficult for full lung expansion. They may have an everted umbilicus, or basically an outy belly button, and diminished bowel sounds, just because I'm not saying the bowel sounds are necessarily hypoactive, but they're just harder to hear, and that's because you have to listen through all that fluid. There could be the presence of a fluid wave, which nursing schools love to teach about. It's not done all that often, but I'll talk about it here just in case it's on an exam. And a fluid wave is detected by having an assistant press down on the midline of the abdomen with their hand. And then the examiner taps one side of the abdomen and feels for that tap or feels for that fluid movement on the other side. And it's not always accurate, and it requires a second person, so it's not done a lot, but it's one of those things that always tends to show up on nursing school exams. Another Kind of physical assessment finding would be dullness on percussion of the flanks, and this dullness can shift. So, depending on the patient's position, if they change position and the fluid moves away from one flank, you wouldn't have dullness on that flank. But if they turn the other way and now that flank has fluid near it, then you percuss, and then that side would have dullness. So we call that a shifting dullness at the flanks. And then if this is caused by cirrhosis, which again, in many, many cases it is, then you'd see signs related to liver disease, such as spider angiomas, caput medusae, which is that engorgement of vessels, which you can really see around the umbilicus on the abdomen, palmar erythema, and of course, jaundice. So now that you suspect your patient has ascites, there may be some tests that are done, and the most cost-efficient, easy, non-invasive way to test for ascites is with ultrasound. Though in some cases, you may see CT scan used or MRI used, especially if they're still trying to figure out what's causing the ascites. Now, the fluid from the abdominal cavity may also be evaluated to help determine the cause of the ascites if it's unknown and to rule out peritonitis. Now, speaking of peritonitis, let's talk about the complications of ascites, and definitely peritonitis is one of them. But first, let's talk about something much more common, which is respiratory compromise. So when the abdomen is significantly enlarged, patients can definitely suffer respiratory compromise and require oxygen therapy. Many times, what you'll notice with these patients is they're very tachypnic and taking shallow breaths. So the reason for this is because, again, they're not getting good lung volumes because there's just no space. Their belly is much, much bigger than normal. So faster respiratory rate and shallow breathing. Now, let's say you've got a patient who's breathing fast, not getting a lot of oxygen. What do you think is going to happen after a period of time? Do you think they can sustain that for a long time? Absolutely not. So if your patient doesn't get treatment, they're showing signs of respiratory compromise, at some point they're going to tire out, and then respiratory failure can result. So that's one key complication of ascites, respiratory compromise. And then hypotension can occur. If enough fluid leaks out of the vascular space and into the peritoneal cavity, what do you think that does to intravascular volume? It lowers it. What do you think that does to preload? Preload is lower. What does that do to cardiac output and stroke volume and all of those things? They're going to be lower. So hypotension can result. Now, let's talk about peritonitis. Peritonitis can occur when that fluid becomes infected, and patients can get very, very sick from peritonitis. Some key signs of peritonitis would be a rigid and very, very painful abdomen, fever, and elevated white blood cell count. Another complication of ascites is pleural effusion. Acidic fluid can seep into the peritoneal space, causing a pleural effusion, which drastically affects lung volumes and can lead to significant respiratory compromise as well. And then abdominal hernias. Abdominal hernias can occur in patients with ascites due to a combination of factors. One is decreased nutritional intake, which leads to weakened muscles, and specifically, we're talking about weakened muscles of the abdominal wall. And then when you combine that with increased abdominal pressures, can lead to the development of hernias. And hernias, I know they're super common, but in patients with ascites, high risk for them to become strangulated or even rupture, which leads to significant complications such as septic shock and even death. So your complications for ascites, and there are probably others, these are the key ones, are going to be respiratory compromise, hypotension, peritonitis, pleural effusion, and abdominal hernias. So now you're probably thinking, what are we going to do about this? This poor guy with ascites, how are we going to fix him? So the treatments for ascites are threefold. We've got lifestyle therapies, we've got pharmacology, and we've got an invasive procedure. So lifestyle therapies for ascites are going to be basically following a low sodium diet because that's going to help reduce fluid retention. Now, if the ascites is associated with cirrhosis, we want to make sure the patient also avoids alcohol to prevent further liver damage. Now, with that, they should also avoid medications that can harm the liver, such as NSAIDs and acetaminophen. So, lifestyle therapies. Again, that's going to be low sodium diet, avoiding alcohol, and avoiding any medications that can harm the liver. Next, we have pharmacology. Diuretics are the name of the game when we're looking at treating ascites. Diuretics can help remove the excess fluid associated with ascites, and generally what we see is the combination of furosemide and spironolactone used together. Occasionally, you will see albumin used to help increase oncotic pressure and pull fluid back into the vascular space. So if you see that for your patient, that is why they've been ordered albumin. And then I mentioned an invasive procedure. That is a paracentesis. Patients with large volume ascites, again, that's called tense ascites, have excess fluid removed via paracentesis. In many cases, that fluid is evaluated in the lab to determine the cause of the ascites if it's unknown, and also to rule out peritonitis. So paracentesis involves simply inserting a needle into the peritoneal cavity to drain the excess fluid. So the patient is not sedated or anesthetized for this. They are given local anesthetics, in that area to make it as painless as possible. So they'll notice the injection from the local anesthetic, but then once they're numb, they don't feel anything. And every time I've seen paracentesis done, patients feel immediate relief, immense and immediate relief, because that fluid is gone. Now, that sounds great, right? Of course it does, but there are also some complications that can occur with paracentesis. That includes bowel perforation, infection, electrolyte imbalances, pleural effusion, and bleeding. Again, paracentesis, very effective, not super invasive, though it does come with some risks, and it does provide pretty much immediate relief of symptoms. Okay, now that you have some understanding about ascites, let's do an ascites case study / care plan together. Okay, you ready? Alrighty. Your patient is Bob. He's a 57-year-old male. He was admitted to the hospital with complaints of abdominal distension, abdominal discomfort, shortness of breath, and generalized weakness. Bob has a past medical history significant for alcohol use disorder and cirrhosis. So when you do your physical assessment of Bob and take his vital signs, here's what you notice. Bob appears jaundiced with yellowing of the skin and the sclera. He complains of that abdominal discomfort and that abdominal distension. You look at his abdomen, it is grossly distended with shifting dullness noted on percussion. Auscultation reveals diminished but normoactive bowel sounds. He is tachypnic with a respiratory rate of 26 breaths per minute and has diminished breath sounds at the bases. His heart rate is 92 beats per minute. Blood pressure is 127/63. SpO2 is 89% on room air, and temp is 36.9 degrees Celsius. Bob tells you he started feeling pretty bad after enjoying fried chicken from his favorite fast food restaurant a day or two ago. So that is your assessment of Bob, and you send off some labs and you get those back, and these labs show elevated liver enzymes, as we would expect. We have low albumin levels, which makes sense, and a prolonged prothrombin time, which is something associated with liver disease. The liver makes clotting factors, and in patients with liver disease, they don't have enough clotting factors, so they are prone to bleeding. All right, the diagnosis is officially in. The MD diagnoses Bob with tense ascites, secondary to cirrhosis and that portal hypertension. So what is she going to do about it? She's going to be doing a paracentesis. She's going to prescribe pain medication to use PRN, and we're going to give oxygen to Bob to maintain an SpO2 above 95%. So now let's look at how we would take all of this and write a nursing care plan. So what might that look like? How about a diagnosis of impaired gas exchange related to ascites as evidenced by SpO2 89% on room air and respiratory rate of 26 breaths per minute. So that's our nursing diagnosis. Impaired gas exchange related to ascites as evidenced by SpO2 89% on room air and respiratory rate of 26. We could also add to that diminished lung sounds in the bases. So now we need to have a goal for Bob. All of our nursing care plans have a goal. What are we trying to achieve? And this goal has to be SMART, right? SMART goals: specific, measurable, attainable, realistic, and time-bound. So a SMART goal for Bob with this problem could be Bob will achieve SpO2 greater than 95% within 1 hour. Okay, we don't have a lot of time. We don't want to mess around. Airway's important. Respirations are important. Oxygenation is important. We're going to try to get that level up pretty quickly. Our interventions are going to be things like administering oxygen as needed, maintaining a position of comfort. Whatever position Bob feels like he can breathe best in, let Bob be in that position. Monitor SpO2 and respiratory rate, and prep the patient for therapeutic paracentesis, because that paracentesis is going to be the thing that improves his respiratory status. Here's another diagnosis: risk for infection related to paracentesis. So our SMART goal or SMART objective would be something like Bob will show no signs of infection by time of discharge. The interventions, how we're going to get to that goal, will be things like maintaining a clean and dry dressing at that paracentesis puncture site, performing hand hygiene anytime we interact with Bob, teaching Bob to perform hand hygiene. We're going to monitor the dressing for any purulent drainage or the area around it for any redness and warmth. And we're going to monitor Bob for other signs of infection like fever or elevated white blood cell count or tachypnea not related to ascites or tachycardia. And then one more nursing diagnosis. We've got a knowledge deficit with our friend Bob. How about knowledge deficit related to dietary guidelines as evidenced by patient statement he ate fried chicken from a fast food restaurant? Bob, come on, buddy. So our SMART goal here is Bob will state 3 types of food to avoid when following a low sodium diet by time of discharge. What are our interventions? Our interventions are going to be, first off, let's assess Bob's readiness to learn. Right now, his oxygen saturation level is 89%. He's breathing 26 times a minute. He's in pain. Is he ready to learn right now? No. So later, when he's feeling better, we'll assess his readiness to learn again, and if the time is appropriate, then we'll dive into it. We want to assess what Bob already knows about a low sodium diet. We want to educate Bob on high sodium foods to avoid, and educate Bob on the connection between sodium and fluid retention. So there you go. I hope that helps you understand ascites and give you a little bit of an insight into writing a nursing care plan, something that I know nursing students, especially newer nursing students, really struggle with. So I hope that helped. Now, if you are listening to this podcast, obviously you love it, but I hear from a lot of students, sometimes they're like, there's so many episodes, I don't know where to start. That is not a problem anymore because I have created something called the playlist prescription. So just go to straightanursingstudent.com/prescription and let me know what you're learning about right now, and I'll send you a customized playlist of the episodes that will help you the most. So that is called the playlist prescription, and you can get that at straightanursingstudent.com/prescription. Thank you so much for hanging out with me. to learn about ascites. And if you're not yet following or subscribed to the show, please do that now. I'd love to read your 5-star review as well if this podcast helps you feel more confident in nursing school, or as a nurse, feel more confident at the bedside and working with patients. And then I will see you back here next week. I haven't picked a topic for next week yet, so it will be a surprise. I think it'll be a pediatric topic. I'm not entirely sure. Don't hold me to that. Possibly it will be a pediatric topic. If not, it'll still be something amazing. So I'll see you back here next week for that. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.